my name's Stephen Malarchik, and this talk is going to be over hyperkalemia. Some of the objectives of this talk is to first define hyperkalemia, then we'll review the physiology of potassium and how it works in our body. We'll also discuss the causes of hyperkalemia and some causes of pseudo-hyperkalemia. We'll list the signs and symptoms of hyperkalemia, and then we'll finish with a discussion about how to treat hyperkalemia, and then specifically how to treat hyperkalemia in EMS at the paramedic level. So first, I need a little disclaimer. Some of the things that I talk about and some of the treatments for hyperkalemia that are in the presentation, you may not be able to do. You want to make sure that whatever you do is in your scope of practice and approved by your medical director. So Tabor's definition of hyperkalemia is an excessive amount of potassium in the blood. Well, when we look at a serum sample of potassium, the normal level is about 3.5 to 5 milliequivalents per liter. Hyperkalemia is considered to be anything over 5.5. When we talk about how potassium works in the body, we need to remember that potassium is the most common intracellular cation. And you probably also remember that a cation is a positively charged ion. Potassium is commonly noted as a capital K with a superscribed plus sign. Potassium is part of the sodium and potassium pump that's found in our cell membranes. So like we said, potassium is the most common intracellular cation. The serum level is 3.5 to 5, but actually the level within the cells is about 150 milliequivalents per liter. So you can see here from this picture that the sodium-potassium pump takes energy to work, and so that energy is in form of ATP. So for every time the pump works, 2 molecules of potassium go into the cell against the gradient, and 3 molecules of sodium go out the cell against the gradient. As part of cell depolarization, both potassium and sodium channels are opened up, which causes each cation to rush out, changing the charge of the cell. It is during cell depolarization that the pump resets the charge by moving sodium and potassium in opposite directions against the gradient. This pump also enables glucose, amino acids, and other nutrients to be transported into the cell. Our bodies have about 4,000 milliequivalents of potassium. We ingest this from our diet. We ingest about 40 to 150 milliequivalents per day. Our potassium levels are controlled by our kidneys. The kidneys are a weak reabsorber of potassium. There is always loss of potassium even when the serum level is low. The kidneys do a much better job of holding on to sodium, so an imbalance between sodium and potassium can precipitate quickly. You probably have realized that dysfunction with the kidneys can cause major potassium problems with the patients you've seen in EMS, particularly renal patients. Also, diuretics, which manipulate urine formation in the kidneys, can cause problems with potassium levels. In fact, any medication that affects the kidneys can affect potassium levels. An artificially high serum potassium level may manifest by leaving the tourniquet on for too long prior to drawing blood. This is considered a pseudo-hyperkalemia. Another problem is if the phlebotomist uses too small of a needle or too much negative pressure to draw the blood sample. This can cause cell lysis, or the cells just explode, which then releases all the intracellular potassium into the sample. And then of course all that potassium raises falsely what the result is on the lab sample. Also, other causes of the pseudo-hyperkalemia include increased red blood cells, polycythemia, increased white blood cells, leukocytosis, and increased platelets or thrombocytosis. These can all cause a false increase in potassium. While the sample is in the tube, a certain amount of potassium leaks out of the cells. Of course, this would be a higher number of cells in the sample. There are several causes of hyperkalemia that we're going to look at a little closer. The first is excessive dietary or intravenous intake. Then we'll talk about renal failure a little bit, problems with aldosterone, crush injuries and transfusions, infection, acidosis, dehydration, and medications. So we all know bananas have a lot of potassium in them, but on this screen, bananas have the lowest amount of potassium in them. White beans, spinach, apricots, avocados, baked potatoes, baby acorn squash, salmon, mushrooms, and are also all high in potassium. And of course, a person could get too much potassium if they're getting IV potassium in a facility. Low urine output, also called oliguria, or absent urine output, also called anuria, will raise the potassium due to not having enough flow of blood to excrete the cation normally. These low flow states can be caused by renal damage. This can be either acute or chronic, or by hypovolemia. Either way, the kidneys are not able to excrete enough potassium, and then the dietary intake begins to accumulate. Renal damage can also be caused by many other things, including medications, trauma, diabetes, exposures to toxic substances, and illicit drugs. Aldosterone is a major controller of potassium excretion in the kidneys. Aldosterone is produced in the adrenal cortex, and it's a hormone and can be stimulated in response to several things. Aldosterone is part of the renin-angiotensin-aldosterone system. Increased aldosterone lowers potassium, and decreased aldosterone inhibits potassium excretion, causing an increase in serum potassium. Decreased aldosterone can be from diseases such as Addison's, and medications such as spironolactone and angiotensin-converting enzyme inhibitors, which are also known as ACE inhibitors. Potassium can go up in the case of crush injuries and burns, mostly because of both cause massive cell damage, and when cells are damaged or lyse, they pour out all their contents. Remember that inside of each of the cells there is a lot of potassium, and so that will drive up potassium when you get major crush injuries or traumatic injuries and then burns. As blood ages in storage, the sodium-potassium pump breaks down slowly, shifting electrolytes. As the blood gets older, the potassium level increases greatly. Most bank blood can only be stored for about 42 days. Research shows that potassium levels when the first day the blood goes on the shelf is about 2.1 milliequivalents per liter, and then it will gradually increase to 45.3, give or take a little bit, on day 42. Some research shows that it may go as high as 65 milliequivalents per liter, and then those packed red blood cells get infused into patients, which can potassium elevate. Hyperkalemia in sepsis patients may be attributed to acidosis. Acidosis causes an elevation in potassium due to the cellular buffering system. Anaerobic metabolism, or metabolism without oxygen, produces lactic acid. As this lactic acid accumulates, the body tries to correct the pH by exchanging hydrogen in the extracellular space for potassium in the intracellular space, basically trying to hide the hydrogen to cause the pH to be less acidic. This causes an increase in potassium. Eventually, if the anaerobic metabolism is not corrected, the cells begin to die, releasing their potassium into the intravascular space, therefore driving up serum potassium levels. Of course, when we lose total body water from our system, our serum is going to become more concentrated, and and so that will cause an increase in potassium. It's easily corrected. You should be able to rehydrate the patient and that potassium back to normal. Research has reported that 75% of patients with severe hyperkalemia had renal failure. 67% were taking a drug that predisposed them to hyperkalemia. Medications can have effect on potassium levels. Some of the medications are angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, penicillin G, spironolactone, and succinylcholine. This list is not inclusive, but does include some of the main players in hyperkalemia. ACE inhibitors and ARBs are used in the treatment of hypertension. They work by either inhibiting either the production or the effect of angiotensin II on the body, but they also block the production of aldosterone, which we have already learned is one of the main controllers of potassium in the body. This causes an increase in potassium. Penicillin G contains potassium. Now, normal people can handle the extra potassium, but patients with renal impairment may develop hyperkalemia from using either IV penicillin G or oral penicillin G. The diuretic spironolactone is an aldosterone blocker. Blocking of aldosterone inhibits the excretion of potassium, which will cause hyperkalemia. This effect is more profound with renal impairment and taking other medications that will alter renin production, such as NSAIDs and beta blockers. Succinylcholine is a different story altogether. Used in rapid sequence inhibition to cause paralysis by depolarization at the neuromuscular junction, it causes an increase in serum potassium of up to about 0.5 milliequivalents per liter in normal people. This typically isn't a problem. Most people can handle this little increase. Problems arise when the patient has an upregulation of nicotinic acetylcholine receptors in the skeletal muscle from various pathologies. These are all found in the parasympathetic nervous system. Patients with burns, crush injuries, severe infections, spinal cord injuries, stroke, multiple sclerosis, amyotrophic lateral sclerosis, Guillain-Barré syndrome, and wound botulism are all at risk for upregulation of these acetylcholine receptors. Acute injuries such as burns, crush injuries, stroke, infection, and spinal cord injury usually take up to about 5 days from the onset of the injury or infection to have an upregulation of these acetylcholine receptors. Therefore, it's usually safe to use these during the initial care of the patient. Advanced Burn Life Support recommends not using succinylcholine 1 day after injury until 1 year after the injury. Most texts say that upregulation usually disappears in these injuries and infections after about 6 months. Multiple sclerosis, amyotrophic sclerosis, and muscular dystrophy have upregulation all the time, so succinylcholine should not be used when the patient has these. Guillain-Barré is a transient denervating disease, and succinylcholine would be contraindicated while they have the disease until well after it has resolved. These signs and symptoms may be present as the patient's potassium levels increase, and maybe they're presenting complaints to EMS. A 12-lead EKG should be completed for suspected hyperkalemia. As the potassium level goes from 5.5 to 6.5, the patient can develop narrow peak T waves. However, they only develop in about 22% of hyperkalemic patients, so about 1 in 5 will have narrow peak T waves. To be considered peaked, they need to be at least 2/3 the height of the R wave. T wave changes are usually in leads V2 through V4 on the 12 lead. And then they may also be seen in all leads, kind of a diffuse finding of these tall peak T waves. This EKG is from a patient with a serum potassium of about 7.0. Note the tall peak T waves in multiple leads. When potassium gets over 7.0, you can start having a lengthening of the PR interval also. So here's these nice big peak T waves. Narrow. Most of them are greater than 2/3 the height of the R wave. I'll give you a couple minutes to look at that. Well, a couple seconds. Well, as the potassium level passes 7.0, T-wave flattening occurs, and ST segment depression appears and the QRS begins to widen. Although you don't see really good T-wave flattening here, you still have some good peak T-waves in some of the V leads. You do see that the QRSs are starting to widen. There's your big peak T-waves, increasing QRS width. As the potassium continues to climb, the sinoatrial node stops setting the pace altogether, causing either the AV junction or the ventricles to take over. This can cause bradyarrhythmias. Shortly thereafter, ventricular fibrillation and asystole is going to follow. This patient had a potassium of 9.9. A common feature prior to cardiac arrest is a sine wave pattern on the EKG, which this 12 lead also reflects. These are considered big sine waves. Doesn't look good. There are 3 approaches to managing hyperkalemia. In severe cases, usually all 3 are employed. Some of these are available in the field to EMS providers. The first approach is to stabilize the membrane from effects of potassium, especially important in the heart. This can be done with calcium. The usual dose of calcium gluconate is about 1 gram, or 10 milliliters of a 10% solution. This is infused over 2 to 3 minutes intravenously. The usual dose of calcium chloride is 0.5 to 1 gram, which is 5 to 10 milliliters of a 10% solution. This also is infused over 2 to 3 minutes. It is imperative that the patient be on the cardiac monitor. Also, try to use a big vein for calcium chloride, as it is very irritating to cells. The effects of calcium will begin within minutes and may start to wear off in about 30 minutes. Calcium decreases the excitability of the myocardial membranes. The effects of calcium do start within minutes of administration, but remember, this does not influence the serum level of potassium. The second approach is to try and drive the extracellular potassium back into the cells, or the intracellular space. This will lower hyperkalemia. It can be accomplished by administering regular insulin and glucose IV. Insulin enhances the activity of the sodium and potassium pump, which drives potassium back into the cell. Glucose is given so the patient does not become hypoglycemic from all of the insulin. This will start to have an effect on the potassium level in about 20 to 30 minutes after administration, and the potassium should lower by 0.5 to 1.2. Beta-2 agonists also improve the activity of the sodium-potassium pump and increases movement of potassium back into the cell. Albuterol will cause this shift. It is recommended that the patient be given a neb of 10 to 20 milligrams of albuterol, or 0.5 milligrams IV of albuterol. Most ambulances only carry the nebulized form of albuterol, so we'd want to give this higher dose of 10 to 20 milligrams. This can lower the serum potassium by 0.5 to 1.5 milliequivalents per liter. The evidence for causing a pH shift, which causes potassium to be exchanged for hydrogen in the cell by using sodium bicarbonate, is poor. If your protocol calls for the use of bicarbonate, remember not to infuse it in the same line you are giving calcium. It will precipitate into calcium carbonate, which is otherwise chalk. The last approach is to remove the excess potassium from the body, and there's a couple of ways to do that. Loop and thiazide diuretics, so Lasix or furosemide, HCTZ or hydrochlorothiazide are examples. These have the side effect of causing potassium excretion from the kidneys. Exchange resins are administered through the GI tract and exchange potassium for sodium. It does this pretty slowly. The dose is 15 to 30 grams every 4 to 6 hours until the potassium level is back within range. This may take several days. However, dialysis is a quick and effective way to normalize the serum potassium level if that's available to you. So in summary, we'd like to cover the EMS treatment for hyperkalemia. Of course, all the time you want to make sure that you're covering your ABCs. Airway management, if they don't have a patent airway, you want to go ahead and give them a patent airway. And you want to make sure they're not hypoxic, so oxygen is definitely appropriate. And so make sure they're ventilating and oxygenating well. Then IV access, and when you start IV access, consider if you're going to be giving calcium chloride that you would want a large bore IV in kind of a central location, so either AC or external jugular. We'd want to have the patient on the cardiac monitor, so we can be monitoring their heart rhythm, and then also do a baseline 12 lead to look for peak T waves and widening QRSs and arrhythmias. If time allows, really thorough sample history would be useful. Making sure that the patient's not allergic to any of the medications we're going to be giving them, making sure that maybe they're not on medications that would have caused their hyperkalemia, and that they don't have a history of disease that might have caused their hyperkalemia. For patients with suspected hyperkalemic arrest or near arrest, you should consider giving calcium 1 gram IV over 2 to 3 minutes. And then albuterol as a nebulized treatment, usually taking 10 to 20 milligrams, which is a lot more than we normally do, and mixing it in 4 milliliters of saline. And the last thing is, of course, rapid transport. Hospitals will have some of these other things that we can't do in the field, like the insulin, the dialysis, and the exchange resins. So the quicker we can get the patient there, the quicker they can start on those therapies. Of course, it's also important to follow your own protocols. And if the patient is in arrest, you also want to follow your own ACLS guidelines. Well, thank you for your time. And there should be an article after this that you can read on hyperkalemia, and then a short quiz to finish things up. So thanks.